patient with a multinodular goitre who is posted for total thyroidectomy. And it's my pleasure to invite the external examiner for this session, Dr. Ranju Singh. Ma'am is an eminent faculty with a lot of clinical and teaching experience. She is working as Director Professor in Lady Hardinge Medical College and Associated Hospitals, New Delhi. And ma'am's area of special interest are pediatric anesthesia, obstetric anesthesia, and life support. We welcome you, ma'am. Moderating this session, we have Dr. Sheetal Singh. She is working as Assistant Professor in the Department of Anesthesia at RML Hospital. And her areas of special interest are fellowship in pain medicine that she's done. So definitely has an interest towards pain, then kidney transplant anesthesia, difficult airway, and obstetric anesthesia. We welcome you. The case will be presented by Dr. Sandra. She is a postgraduate student with us in RML Hospital. Over to you, ma'am, for the proceedings of the session.
Thank you so much, Dr. Nitin, and a warm welcome to all the students who are listening in. We'll be discussing a long case of a large thyroid swelling. And now I would request Dr. Sandra to please present her case.
Good morning, ma'am. Am I audible?
Yes.
Good morning, ma'am. Ma'am, I'll start with the presentation. My patient is Mrs. Shabnam, a 30-year-old female. She is a housewife by occupation and is a resident of Faridabad. My patient presented with chief complaints of swelling in the midline of the neck for 12 years. History of present illness. My patient was apparently asymptomatic 12 years back when she noticed a swelling in front of the neck, which was insidious in onset, painless, gradually increasing and progressive in size. It was initially the size of a pea. It gradually increased to attain its present size. My patient also gives history of weight loss 5 years back, noticed by loosening of clothes, but she could not quantify the exact weight lost. She also gives...
Wait. So you have this patient who's come to you with a large swelling in the neck.
Yes,
okay?
ma'am.
Now, just on initial seeing the patient while you're taking the history, you want to take a history which will now help you reach a differential diagnosis, right?
Yes, ma'am.
What other swellings are present as midline swellings in the neck before you move on to the rest of the history, which will be guided with what has come to you as a differential diagnosis when you see this swelling? So which are the other swellings which are there in the midline in the neck in an adult patient?
Ma'am, a thyroglossal cyst, submental lymph nodes, a lipoma of the mental region, a dermoid cyst, and Ludwig's angina.
Okay. You can also have probably a reactive large lymphadenopathy or any neoplasm of these structures which are present in the center of the neck, which could be a thyroid, a parathyroid, a laryngeal, or a pharyngeal neoplasm. Besides this, as you've said, a dermoid cyst, a thyroglossal duct cyst, any of these can be present in the midline, and the remaining history now should help you localize and identify what kind of swelling this is. Okay?
Yes, yes.
Started well. You've initial history is related to the size and onset and the progress of the swelling. So you're also saying that she has a history of weight loss.
Yes, ma'am.
Okay, please carry on.
My patient also gives history of increased appetite and increased sweating. Okay. No history of fever, no history of discharge or sinus from the swelling, no history of rapid increase in size with pain, no history of appearance of new swellings anywhere else in the neck or body, no history of cold intolerance, loss of appetite, cold intolerance, weight gain, tiredness, shortness of breath, mental slowing, constipation or vision abnormalities. No history of
this history.
Ma'am, I'm trying to rule out hypothyroidism.
Had increased appetite and she's had weight gain, weight loss initially. Why you've taken this history of constipation and vision abnormalities and cold intolerance?
Ma'am, to rule out hypothyroidism.
Okay. So since one of the commonest swellings in the center of the neck will be a large thyroid, particularly in a female, you are now trying to elicit history probably which is related to hypo and, as I can see from your slide, hyperthyroidism, right? So
Yes, ma'am.
related to what all should you, if you've identified that this is probably a large thyroid swelling, what is the focus of your history? What do you achieve by taking a detailed history like this? What are you trying to do?
Ma'am, there is a thyroid swelling. I first need to come up with the etiology, then whether it's a hypothyroid, is it due to hypothyroidism or hyperthyroidism? And then I need to elicit if there are any compression symptoms.
Okay, so if you have identified it's a large central swelling, which can probably be a thyroid gland, the history should focus on compressive symptoms caused by that swelling, which you have already taken, then history related to hypo or hyperthyroidism, then history related to probably ruling out any other comorbid condition. Okay, that should be the focus of your history. Please carry on.
No history of heat intolerance, palpitations, tremors, easy fatigability, restlessness, or diarrhea. There was no difficult.
Because you are trying to rule out
hyperthyroidism.
Okay, okay.
There was no difficulty in swallowing of solids and liquids, no history of hoarseness of voice, no breathlessness on sitting or lying down.
Okay, why is this history important? Hoarseness of voice and breathlessness while lying down or sitting down?
These can all occur in case it's a large thyroid swelling, which is causing compression.
Okay, so these are basically compressive symptoms. Swallowing of liquids and solids means there's compression on the esophagus. Hoarseness of voice indicates compression where?
Ma'am, on the vocal cords.
On which nerve? The swelling will never compress the vocal cord. It's not an intratracheal swelling.
Ma'am, recurrent laryngeal nerve, ma'am.
Recurrent laryngeal nerve. So it's compression of the recurrent laryngeal nerve. And breathlessness on sitting down or lying down?
Ma'am, the trachea.
Okay, fine. Carry on, please.
Past history. My patient gave a history of surgery for gallbladder removal 3 months back at a private hospital, which was uneventful. No history of any radiation exposure in the past. No history suggestive of tuberculosis, diabetes, hypertension, or jaundice. Personal history, patient belongs to lower socioeconomic status, consumes non-vegetarian diet. There is no history of consumption of alcohol or tobacco. Bowel and bladder habits are normal. Normal sleep-wake cycle.
Okay.
Menstrual history. My patient achieved menarche at 15 years of age. Earlier, patient had regular cycles, but since the past 4 years, patient complains of increased flow and frequency. Family history, no history suggestive of similar complaints among family members. Obstetric history, my patient.
Is this significant? Is your menstrual history, you said that for the past 4 years, she's complaining of increased flow and frequency. Is this significant?
Yes, ma'am. Menstrual abnormalities are seen in hyperthyroidism and hypothyroidism. Hyperthyroidism is associated with increased flow and frequency, and hypothyroidism with oligomenorrhea.
Please carry on.
Obstetric history. My patient is a para 3, live 3, abortion 0. She gave history of last childbirth 3 years back. All are full-term normal vaginal deliveries and were uneventful. Treatment history. My patient is on tab methimazole 5 mg thrice daily and tab propranolol 20 mg twice daily since 6 months. There is no.
She's given you this history. She's shown you because you very precisely mentioned her medication. How do you know she's taking all this? Did she tell you that?
Not the names of the tablets, but she brought it with them.
Okay,
with
so
her.
That these were present with her.
Yes, ma'am.
Okay, carry on. Please, this is for all the students who are listening in. Do not mention specific name of medication unless either the patient tells you, or as in this case, she has got the medication with her and shows them to you. If that is the case, only then mention specific names. Otherwise, do not mention these names if the patient doesn't tell you. Okay, please carry on.
No other medical or indigenous treatments were taken for the swelling. No history of any other drug intake.
Okay. So what has been the positive finding in your history?
Ma'am, history of a midline swelling in the neck for 12 years, history of weight loss, history of increased flow, menstrual irregularity, increased flow and frequency, and increased sweating.
Weight loss and increased appetite are probably the only positive features in your history. And given that it's a midline swelling, these features indicate a condition of patient
hyperthyroidism.
Okay, please carry on with the examination.
General examination. My patient is conscious, oriented to time, place, and person. She's sitting comfortably on the bed. Weight 51 kgs, height 157 centimeters, BMI of 20.6 kg per meter square, BP 128 by 84 mmHg measured in the right upper arm in sitting position, pulse 82 per minute, temperature 37.2 degrees, respiratory rate 14 per minute. It is normal, abdominothoracic, JVP could not be assessed. Facial skin and hair texture are normal, no pallor, icterus, cyanosis, clubbing, lymphadenopathy, or edema. Then the eye signs. There was no true or apparent exophthalmos. Sclera above cornea was not visible. No retraction of upper eyelid, no lagging of the upper eyelid on looking downwards, no absence of wrinkling of forehead on looking upwards. Eyes are able to converge, no tremors.
Okay, now for all the students listening in, since Sandra is not physically sitting in front of me and I can't ask her to elicit these signs, but please make sure that you know how to examine the patient and elicit these signs on the patient. Any time your examiner can ask you to show him how to do probably the Van Graaf sign or the Dalrymple sign and ask you to examine the patient in front of you. So do not rattle them off just like that. Make sure that you know how to do these tests, okay? Your surgeon colleagues will tell you if you don't know, and there is enough literature available. If you remember from your UG days, you had this manual called S. Das, which you read for surgical examination of the patient. It's a very useful text, and you can read examination of the thyroid gland from S. Das and make sure that you know how to physically examine the eye signs as well as detailed examination of the thyroid gland. Okay, please carry
on. Airway examination, face symmetrical, nose bilateral, nares are equally patent, no DNS, no growth. Malar region and cheeks normal, no gross facial deformity. Teeth, no loose, artificial or buck teeth. Interincisor gap is 4.6 centimeters. Oral cavity normal. Oral hygiene is good, no arched palate. Tongue is normal. MP grade 2, lower jaw, no retrognathia, prognathia.
Do not use abbreviations. MP grade is no sentence. What is MP? I may not.
Malampati grade.
Please. So Malampati grading, use of words like rock and iso and thio are to be avoided. Use full terms and full names. So Malampati grade is 2. Okay?
Yes.
Please carry
on. Lower jaw, no retrognathia or prognathia. Upper lip bite test, class 1. Neck swelling in the midline of the neck. Extension normal, flexion limited due to swelling. Sternomental distance could not be measured. Thyromental distance could not be measured. Neck circumference 41 centimeters. Cricothyroid membrane not appreciated. Spine normal.
So when you examine the airway, examine from one end to the other. It looks very difficult to do, but it's very simple and comprehensive. This is known as the line of sight examination. When you examine from one end, that is, you look at the patient, you look at the nose, the nasal patency, you look at the mouth, the teeth, the tongue. Then you look at or ask the patient to open the mouth so that you can see the malampatti, you can see the tongue, you can see the tonsils and the other structures in the mouth. And then you do all the distances followed by the flexion and extension. And lastly, do not forget to isolate and identify the cricothyroid membrane. So it's not very difficult. Please go about it in a systematic manner. And my suggestion to all the students is please do not mention thyromental distance or any other distances in finger breadths. No mouth opening is acceptable in finger breadths. even if it's for the patient's fingers. It's not that if it's the patient fingers, it's acceptable, but the patient finger may also be of different centimeters. A thin patient who's 30 kg will have 3-finger breadth as 3 centimeters, whereas a patient who's 110 kgs will have 3 fingers as 6 centimeters. So mouth opening is not to be mentioned in finger breadths, must be mentioned in centimeters. All the distances which you do, including the neck circumference, should be measured in precise centimeters. Okay, so please take care that you do not mention finger breadths. Carry on, please.
Local examination, inspection, a globular swelling seen in the midline of the size of 8 into 10 centimeters approximately. Extend laterally, medial border of sternocleidomastoid on the right side. Surface was nodular with well-defined margins. Skin over the swelling was normal, no scars, sinuses, or any dilated veins. Movement with deglutition was present. Movement with protrusion. Yes, ma'am.
Deglutition, how is this relevant?
Ma'am, swellings that a thyroid swelling moves with deglutition, ma'am. It moves upwards on deglutition.
Why?
Ma'am, because of the Berry's ligament, which is a condensation of the pretracheal ligament.
Okay, so that means it's attached to the cartilage of the larynx by the suspensory ligament of Berry. You should be able to explain this well if your examiner asks you, okay? This is a confirmation that it's probably a thyroid swelling. Okay, yes, please move on.
Movement with protrusion of tongue is absent. Lower border of the swelling is visible.
Okay,
Palpation.
What do you mean by lower border is visible? You can see the lower end of the thyroid swelling?
Yes, ma'am.
Please carry on. Jaldi karenge, Sandra. You can rush through the findings a little quickly.
Yes, ma'am. Palpation, no warmth, no tenderness. Inspectory findings were confirmed. Swelling, size of swelling is 8 into 10 centimeters. Superior.
Move on, please. Move on.
Okay.
Move on to the next slide.
Lower border of swelling is palpable. Tracheal rings were not palpable below the swelling. No fixicity.
What do you mean by lower border is palpable? Why is that significant?
Ma'am, to rule out retrosternal extension of my thyroid swelling.
Okay. Any other features which are important if you want to find out if it is retrosternal? Anything that tells you it's retrosternal?
Ma'am,
cannot get.
Ma'am, compressive symptoms.
Okay.
Compressive symptoms. And on inspection, if I am able to see the lower border, and on palpation, if I'm able to palpate the lower border of the swelling.
So
then we'll have
history of compressive symptoms on examination. If you can't get below the swelling, what else will tell you that it's retrosternal?
Ma'am,
can you do any
Yes, ma'am.
Can you do any tests to confirm that it's retrosternal?
Yes, ma'am. If I do a Pemberton test, if I ask the patient to raise both hands such that above the head, such that the arms touch the ears, the palms facing towards each other. If the mass is retrosternal and is compressing on my thoracic inlet, the patient will
ask you to do a Pemberton's test. Please make sure that you do it correctly, because I've seen a lot of students just raise their hand above their shoulders. Remember, when you raise your hands, the palms should face each other and your arms should touch your ears. Okay, that is the correct way of doing the Pemberton's test. And if the Pemberton's test is positive, you will have facial plethora, you will have facial flushing, you will have a prominence of the facial and neck veins, you may have a prominent JVP. Sometimes you may even have some amount of respiratory distress. So this indicates that there is a positive Pemberton sign, which indicates that it's either a large thyroid which has become retrosternal, and the Pemberton sign is positive because there is thoracic inlet obstruction by the thyroid. Now, when there is inlet obstruction, there is an obstruction to the venous outflow. Therefore, you have this plethora and you have facial flushing. Okay. All these tests, anything else which can tell you it's a retrosternal goiter besides the history, the examination, the Pemberton's test?
Ma'am, then we'll have to investigate, ma'am.
Okay, a CT and an X-ray.
And a chest X-ray. And a neck X-ray.
And and a CT scan if required to confirm that it's a retro. What is the significance of retrosternal? Why have we spent so much time on trying to figure out if it's retrosternal?
Ma'am, if there is retrosternal extension, first it means it's a large swelling. There could be chances of increased bleeding, and it could be a prolonged duration swelling, which could mean that that there could be tracheomalacia in the post-op period, and
implications for you in the perioperative period. It has a lot of anesthetic significance. There can be evidence of venocaval obstruction. There can be pleural effusions. There can be pericardial effusion, syndrome, compressive effect on surrounding vital structures like the recurrent laryngeal nerve. There can be compression of the trachea, of the esophagus. So there's a lot of significance of a retrosternal goiter. That's why you spend so much time and effort in trying to rule out a retrosternal swelling. Okay, yes. Carry on.
No fixicity to skin, no palpable thrill. Berry's sign is negative. Carotid pulse was palpable. Chail sign negative. Sternocleidomastoid was not prominent. Coccus test on pressing slightly. The patient did not allow me to continue. Percussion rest.
Significance of the Coccus test?
Ma'am, Coccus test indicates when I press both lobes of the thyroid, the patient will develop stridor. It means that there is
one lobe at a time. That means when you laterally compress the thyroid lobe, there is stridor in a patient. Why does that occur?
Ma'am, due to compression of the trachea.
So if I do this, I'm compressing my trachea, I don't have stridor.
Ma'am, but it indicates that my mass is compressing the thyroid.
Okay.
Yes, ma'am.
No, it's all right. Why does the Coccus sign become positive? What is there in the pathophysiology makes this test become positive?
That it is
thyroid in a long-standing large thyroid, because of the constant pressure of the thyroid gland on the trachea, causes a weakening of the tracheal ring. Okay, so when the thyroid gland is compressed, the weakened trachea narrows, and because of this, there is evidence of stridor on doing the Coccus test. Okay, it indicates that the trachea is weakened. There can be tracheomalacia, and also when this thyroid is removed, there will be no further support to the trachea because the tracheal rings were being supported by the thyroid gland. It will collapse and there will be respiratory embarrassment. That is the significance of the Coccus test. Okay, yes, please move on.
Percussion, restant note heard over manubrium sterni. Auscultation, no bruit heard.
Okay. Anything else? Please go on.
CVS
Okay.
inspection.
Positive in your CVS?
Ma'am, there are no positive findings.
Okay, please move on. Is there anything positive in your systemic examination, any of the systems?
No, ma'am.
Okay, so can we have your provisional diagnosis based on this history as well as this examination?
My patient presented with non-tender midline swelling with symptoms suggestive of hyperthyroidism. No retrosternal extension on examination, most probably a case of multinodular goiter.
Okay, so the diagnosis should include 2 or 3 important things. One, that it's a large midline swelling, whether there is any feature suggestive of hypo or hyperthyroidism, whether any retrosternal extension, whether there is any evidence of tracheal compression or not. If there are any associated comorbidities, that should be done. And you said because of, I think, the nodularity which you experienced on examination of the goiter, you've said that it's a large multinodular goiter. You can also, to complete this diagnosis, if it is known to you and the patient has come to you in PSC when you examine her, which is posted for what surgery. So you have a patient with midline swelling, suggestive of hyperthyroidism, no retrosternal extension, probably a multinodular goiter, posted for what surgery?
Thyroid.
So it's a total thyroidectomy, whatever is the surgery the patient is posted for. So that must be included to complete the diagnosis. Okay, so now because of history and examination and because it's a midline swelling, we've established that it's most likely a thyroid swelling. So we will focus our discussion on the thyroid gland. So can you tell me how the thyroid hormones are synthesized in the body? Very quickly,
Yes.
Sandra.
Yes, ma'am. Iodine is reduced to iodide in the
Where does
GIT.
the iodine come from?
Ma'am, from our diet.
Okay, the predominant source of iodine is our diet. Yes.
Ma'am, then there's iodide trapping by the thyrocyte from the blood. Then there is oxidation of this iodide to inorganic iodide by peroxidase. And then there is organification, that is formation of monoiodotyrosine and diiodotyrosine. Then there is coupling reaction. The two diiodotyrosines combine to form T4, and one monoiodo and a diiodotyrosine combine to form T3. Then there is hydrolysis. This this thyroid hormone combines with thyroglobulin, and this is how it's stored in the thyroid gland. It is hydrolyzed for the release of thyroid hormone. Then there's deiodination in the peripheral tissues. T4 is converted to T3.
What does it consist of? How much of T4 and how much of T3?
Ma'am, T4 and T3 are secreted in a ratio of 10:1, ma'am.
Okay, so 90% is T4 and only the remaining 10% is T3. T3 is much more metabolically active as compared to T4. And once it's released, it's also peripheral conversion of T4 to T3. So the entire process of uptake of iodine and its conversion, iodide and its conversion, oxidation to iodine and its subsequent metabolism should be well known to all the students. Your examiner can ask you in detail any of the process of iodine uptake and the formation of thyroid hormone. Now, what is the effect of this thyroid hormone on various organs of the body? Why is it so important to us?
Ma'am, the thyroid hormone is important for carbohydrate, lipid, and protein metabolism. It is also responsible for our basal metabolic rate on the CVS individual systems on the.
So please divide it system wise. Whenever a question like this is asked, what is the effect of this on various organ systems? What about the effect of jaundice? What is the effect of thyroid hormones or anything? Please divide your answer system wise. So even if you forget a little 1 or 2 points, because you've organized yourself, it gives a good message to the examiner that your thought processes are logical and then you have a systemic way of thinking. So the effect of hormone in the body can be divided into the cardiovascular system, on the respiratory system, on the basic metabolism, on the GIT, and on the CNS. These are the various systems where thyroid hormone has its predominant effect. So what's in the cardiovascular system?
Ma'am, it raises the heart rate. It manages, it is responsible for the chronotropic and inotropic effects on the heart.
Positive chronotropic and inotropic.
Positive chronotropic and inotropic heart, and that means it increases the heart rate and the cardiac contractility. Then it also increases the intravascular volume.
It has effects like epinephrine or adrenaline and increases the heart rate, increases the cardiac output, increases the blood volume, also has a positive effect in increasing the numbers as well as the sensitivity of the beta receptors. Okay. What about
the respiratory?
Yes. What about its effect on the CNS?
Ma'am, it increases the respiratory rate and the tidal volume.
CNS. I asked CNS.
Ma'am, it increases the deep tendon reflexes in hyperthyroid. Deep tendon reflexes in hyperthyroidism, they become more rapid. In hypothyroidism, there's slowing. Then in hyperthyroidism, there's agitation, anxiety.
Reflexes and in the entire central nervous system. Okay. What about its effect in the respiratory system?
Ma'am, it increases the respiratory rate and the tidal volume, and ma'am, it decreases the
So a hypothyroid patient becomes
hypo.
a hypothyroid patient has an increased sensitivity to the effect of sedative effect of drugs and has a depression of respiration. The ventilatory drive goes down in patients of hyperthyroidism.
Yes, ma'am. They're more prone to hypercarbemia.
Yes, yes. What about its effect on metabolism?
Ma'am, it increases the BMR. It is responsible for heat production. It is responsible for the growth and maturation of tissues, and it increases sweating, and also is responsible for glycemic control.
Required for skeletal tissue maturation, bone maturation. It's required for normal growth and development. It's required for CNS development. It's required for carbohydrate metabolism, protein metabolism. It enhances lipid metabolism, and it increases the carbohydrate metabolism. So there is a lot of effect of thyroid hormones in the body across all systems. And you should all be well versed with what is the effect of the thyroid hormone, and therefore what are the features of hypothyroidism or hyperthyroidism. Okay, it will be a repetition if we do this, but the question can be formulated by your examiner when he asks you what are the signs and symptoms in a hyperthyroid patient and what are the signs and symptoms in a patient who's hypothyroid. So all this can be detailed at that time. So the effect of thyroid hormones in the body is an important part of your viva, and you should be well versed with features. Now, what is sick euthyroid syndrome? Have you heard of that?
Yes, ma'am.
Okay, so sick euthyroid syndrome is when the thyroid function is depressed without any basic problem with either the thyroid gland or with the hypothalamic pituitary axis. There is a decrease in the thyroid hormone output as a result of acute illness in the patient. So acute infection, trauma, sepsis can produce a temporary decrease in the thyroid hormone output. Therefore, there is features of hypothyroidism without actually anything pathologically being wrong either with the thyroid hormone or with the axis. And when the illness passes away, the thyroid recovers. This is known as the sick euthyroid syndrome. Okay, now you have this patient whom you've taken a detailed history, you've done a detailed examination, you've also made a provisional diagnosis, or she comes to you with a diagnosis. She's come to the PAC for a subtotal thyroidectomy?
Yes, ma'am.
How will you investigate this patient for a subtotal thyroidectomy now?
Ma'am, I will get a complete blood test, a complete blood count done. I will get a random blood sugar.
What do you want in a complete blood count and why?
Ma'am, first of all, it's a major surgery, so I expect blood loss. And on top of that, the patient is on methimazole.
It's a thyroid surgery, not any major surgery. So that means if it's a gallbladder or it's a hysterectomy, the potential for blood loss is different. This is a thyroid surgery, which is a large multinodular goitre in your patient. I wish you had a picture of your patient here, but if she has a large multinodular goitre and it is likely to bleed, this particular surgery, there is likely to be excessive blood loss. That is why you need to have a baseline hemogram. Okay, any reason why you want a hemoglobin?
Ma'am, and my patient is on methimazole.
Okay.
It causes agranulocytosis, and my patient is a hyperthyroid patient, so there are chances of anemia.
Okay, so a hyperthyroid patient per se, because of her disease, will have some amount of anemia. She may have some thrombocytopenia also. Plus, because it's a major surgery and there is potential for blood loss. And thirdly, because she's on drugs which can produce a change in the WBC count. That is all the reasons together why you need a hemogram, complete hemogram, that is a hemoglobin plus all the blood counts together, including a coagulation profile. Okay, because she's likely to have the drugs have a potential of causing agranulocytosis, as well as major surgeries must have a baseline coagulation profile also, because you may end up transfusing some amount of blood to these patients. Okay, any other investigation?
Ma'am, I will get a random blood sugar done.
Why?
Ma'am, because hyperthyroidism is a hypermetabolic state, so the patient could be in hypoglycemia.
Okay. Hypo, you don't know what she has till you do the thyroid function test, but she appears to be hyperthyroid at this time from history, and there can be a change in the carbohydrate metabolism, whatever be the condition of the thyroid gland. So you must have a basal blood sugar level. What else?
Ma'am, I would like to get a kidney function test done and a thyroid function test done.
Why kidney function?
Ma'am, to ensure elimination of all the anesthetic drugs I'm giving.
Okay, for every investigation you do, your examiner can stop you and ask you to explain why. So just don't rattle off all the investigations. Be sure you to think and stop, pause, think as to why you want to get every investigation that you are rattling off. Okay, so why do you want to get a renal function test done?
To ensure elimination clearance of the anesthetic drugs that I'm giving.
You can't ensure by doing a blood test. You can only know the baseline level. Can't ensure. Okay, so you, because all your drugs are excreted through the kidney, probably for any major surgery, you would like to know her basal renal function level. Okay.
Yes, ma'am. Ma'am, a thyroid function test done, ma'am.
Okay, would you like to get an LFT done also?
Ma'am, a baseline if values, yes, ma'am.
Okay, is it a norm in your institute to get baselines LFT done for every surgery or every major surgery?
Every major surgery, yes, ma'am.
Okay. So per se, hyperbilirubinemia or jaundice may be a feature of thyroid disease. That is one reason, and alkaline phosphatase may be raised in patients with hyperthyroidism. That is one reason why you will get an LFT done. And if in your institute it is the norm to get an LFT done for major surgery, say that. If it's not, then you can omit it. Okay.
Yes,
but for surgeries like thyroid, where the thyroid hormone disturbance per se can affect the LFT, plus it's a major surgery, you can also get the LFT done. So till now, we've got a hemogram with blood counts, we've got a coagulation profile, we've got a blood sugar, LFT, and a kidney function test done. Any other thing?
Ma'am, other than that, I can get a chest X-ray, PA.
I think you mentioned
thyroid function test. I mentioned.
Thyroid function में क्या कराना है बेटा?
Ma'am, TSH, T3 and T4.
Okay. Would you like to get a T3, T4 or a free T3, T4?
Free T3, T4 would be better, ma'am.
What is the difference between the two?
Ma'am, it is present in stored form as thyroglobulin. I would like to know the free levels of T3 and T4 in blood.
Anything else? Why a free T3, T4 is better than T3, T4?
Ma'am, during surgery, there will be
free. No. Why is the free T3 called free?
Because it is not protein bound.
Yes. So a T3, T4 level is affected by protein status, protein binding, because it's highly protein. But what are the three proteins that the thyroid hormone is bound to?
Ma'am, thyroxine binding globulin, albumin, and prealbumin.
Okay, so 80% is probably TBG, thyroid binding globulin, and another 15% is prealbumin. The remaining 5% is bound to albumin. And the effect of certain drugs or physiological states can affect the level of TBG in the body. So thyroxine binding globulin is affected by drugs like, say, estrogen or oral contraceptive pills, or drugs like tamoxifen, or even pregnancy. So these states will affect the level of TBG, which means that your thyroid hormone status will not be well elucidated with just measuring the T3, T4. So free T3, T4, which is the metabolically active form, gives you a better representation. So instead of T3, T4, it's better if you get a free T3, T4 done.
Yes.
Okay. And a thyroid and a TSH level.
Yes.
And TSH. Okay, so TSH is very, very sensitive parameter to detect the presence of either hypo or hyperthyroidism. What happens to the TSH?
Ma'am, in hyperthyroidism, it decreases, and in hypothyroidism, it increases.
Okay. And a combination of this TSH together with free T3, T4 will also help you detect whether it is overt hyperthyroidism or subclinical, and overt hypothyroidism or subclinical hypothyroidism. Okay. For example, what happens in a subclinical condition? Are you aware?
Yes, ma'am. In subclinical
What will happen?
hyperthyroidism, the TSH levels are between 0.1 to 0.5.
Free T3, T4 is normal.
Free T3, T4 is normal.
T3, T4 is normal, but the thyroid TSH levels are altered. It is probably it's a subclinical condition, a subclinical hyperthyroidism, which may or may not require treatment. So it has a relevance when these levels come to you with the patient in the PAC. Many a times the resident would not accept, saying that the levels are not all right and patients should be put on T3 or T4 levels need to be normalized. Occasionally, there are now specific guidelines which are available in textbooks that hypothyroidism, which is subclinical up to a certain level, may or may not be treated. But you just have to be cautious that this condition exists. So please read up subclinical hypothyroidism. We can't go into all the details at this time. This will help you decide whether this patient needs to be put on therapy or not prior to accepting the patient for anesthesia and surgery. Okay, so you will do a T3, free T3, T4, TSH. Any other investigation?
Ma'am, a chest X-ray PA view and an X-ray neck AP and lateral view.
Okay, so what does the X-ray neck tell you?
Ma'am, the AP view tells me if there is deviation of the trachea, and the lateral view tells me if there is compression of the trachea and compression of the trachea.
Both of them will also tell you if there is any retrosternal
Extension.
Thyroid, the retrosternal extension. And of course, both views have already said which view will give you compression and which will give you deviation. Any other investigation?
Ma'am, a chest X-ray, ma'am.
Okay, what does the chest X-ray tell you?
Ma'am, the chest X-ray can tell me if there is pulmonary congestion, if there's cardiomegaly. Cardiomegaly can occur both in hypo and hyperthyroidism.
Very good. Okay. And if
there is a pleural effusion.
Yes. So pleural effusion, if there is an enlargement of the heart, pericardial effusion can be suspected. All these conditions greatly affect the chest, the lungs and the pleural cavity. So you can have a detailed evaluation with X-ray, followed by, if there is any finding on the X-ray, like a large retrosternal goiter, or you have some amount of pleural effusion or pericardial effusion is suspected, then you can suggest a advanced evaluation by a CT or an MRI. Okay. Anything else which is of relevance to you?
Ma'am, I can also get an indirect laryngoscopy done
Why is that?
To check the vocal cord movement and to see if for the adequacy of laryngeal inlet.
Not only that, to document, as you've said, the position and the movement of the vocal cords. Why is that important? Particularly as your patient has had a long-standing multinodular goiter. She's had this goiter for approximately 12 years. She has features suggestive of hyperthyroidism, although she has no compressive features and she doesn't appear to have a retrosternal extension. But still, long-standing multinodular goiters or long-standing CAs, whether it is papillary carcinoma or medullary carcinoma, if it's a carcinomatous lesion, it's very important that you get an IL done. Why? You need to document all this for medical legal purposes. You may have these nerves which are damaged during the surgery, and at the end, if you have a patient who's symptomatic with damage to the recurrent laryngeal nerve or superior laryngeal nerve, you must have documented in the file that this is a finding which was present preoperatively or it has developed intraoperatively. So for medical legal reasons, you must document any nerve palsies which you see. Okay. Any investigation which we've left out? An X-ray?
ECG, ma'am.
Yes, ECG. What will the ECG tell you?
Ma'am, my patient is a hyperthyroid patient, though presently use thyroid. If my patient is hyperthyroid, then I can see a sinus tachycardia, arrhythmias like atrial fibrillation or supraventricular tachycardia.
Okay. So rhythm disturbance is very common in hyperthyroid patients. So a baseline heart rate, rhythm disturbance is evidence of hypertrophy, evidence of axis deviation if there is hypertrophy, evidence of any failure is all available if you have an ECG with you. So it's mandatory to do an ECG in hyperthyroid patients. Anything else? And a CT MRI if you feel that there is retrosternal extension, there is intratracheal extension, there is a large thyroid which has got compressive features, you may suggest to the surgeon to get a CT scan done. Anything else? हमने hemogram क्यों कराया था?
Ma'am, for one for baseline values, coagulation profile, ma'am.
वो तो हो गया, कुछ और रह गया. Hemogram क्यों कराया था? हमने क्या बोला था कि इसको क्या होने वाला है?
A granulocytosis हो सकता है.
Blood loss की बात हुई थी ना? कि इसको
Yes,
blood
ma'am.
तो फिर आप
Blood group cross matching.
Blood grouping cross matching. Okay, so that's one of the important investigations. You've talked about blood loss and stuff like that. Anything else? Suppose this was a large goiter, maybe even a multinodular goiter, or even a large colloid goiter. These days, these kind of goiters are not seen. They were seen when I was a student. And why has the incidence of goiter come down so significantly, Sandra?
Ma'am, because of fortification of salt with iodine.
Iodine fortification of the salt, yes. So suppose it was a large goiter with retrosternal extension and the patient had compressive symptoms. Maybe she told you she has dyspnea on exertion and the dyspnea gets worse when she's lying down, and she may have had some hoarseness of voice. She's had a history of 12 years. Would you like to get any one investigation done? What about
ma'am?
Do volume loops give you any information?
Yes, ma'am. The patient's cardiopulmonary status, ma'am.
Not cardiopulmonary status. It tells you flow volume loops. When you chart the flows up with the volume, will give you an idea about intrathoracic or extrathoracic obstruction. Particularly when it's a dynamic airway obstruction, as can happen in a patient. Suppose she's okay when she's sitting down, but she says, I have dyspnea when I lie down. That means it's a dynamic airway obstruction. And the thyroid gland being at the mid part of, it can extend upwards and downwards and can remain intrathoracic or extrathoracic, the swelling. So doing a flow volume loops will give you a very good idea of whether it is an intrathoracic or extrathoracic obstruction. Okay, when there is a plateau in the expiratory limb or whether there is a plateau in the inspiratory limb, will give you very good information about whether it's extrathoracic or intrathoracic obstruction. Although this does not have any influence on the decision for surgery, the obstruction does not decide whether this patient requires surgery or whether she can be managed with iodine, or it doesn't affect her management. But as an anesthesiologist, it will give you a very good idea that this patient is likely to have problems when I induce anesthesia. So flow volume loops can be studied in details by all the students. There are pictures present in textbooks as to what happens when there is an extrathoracic obstruction and what happens when there is an intrathoracic obstruction. Okay, so that is another investigation which can be done. Now you've got this patient investigated. She has a high free T3 and a high T4. She has a low TSH. She has, say, a hemoglobin of about 9. The rest of the investigations are okay. The alkaline phosphatase is slightly raised. Urea creat is okay. Serum electrolytes we've left out. Serum electrolytes should also be done, particularly calcium. Okay, now calcium was slightly on the lower side, as is true with many of us. Would you like to now accept this patient for surgery, or would you like to advise her something before you accept her for surgery?
Ma'am, since this is an elective surgery, I would like my patient to be euthyroid before the elective surgery.
Why do you want the patient to be euthyroid?
Ma'am, if the patient is not euthyroid or if it is poorly controlled TFTs, then there are chances of a thyroid storm in the perioperative period.
Okay. So the morbidity and mortality with a patient who has abnormalities of the thyroid function, whether it is hypothyroidism or hyperthyroidism, is significant because it has such a great influence on metabolism and cardiovascular and respiratory system. It directly influences your outcome of anesthesia. So the morbidity and mortality becomes much higher. Therefore, these patients need to be treated if it's an elective surgery to ensure a euthyroid state before you accept them for surgery. Okay, now how would you put her in a euthyroid state? What drugs will you advise her and how long will you wait?
Ma'am, the drugs that antithyroid drugs that are usually given are thionamides, like methimazole, carbimazole, propyl thiouracil.
Okay.
Then for symptomatic management, I can give beta blockers like propranolol and esmolol. Then iodides are also prescribed to patients for bringing about euthyroidism.
The patient has already, as from your history, I could gather, put on some antithyroid medication.
Methimazole and propranolol.
Where does methimazole act? At what part of the thyroid cycle does methimazole act?
Ma'am, inorganic iodide formation, ma'am.
Okay. Where does propyl thiouracil act?
Ma'am, iodide trapping, inorganic iodide formation, and peripheral conversion.
And the peripheral conversion. So this advantage is not present in methimazole. It's present in propyl thiouracil. That peripheral conversion is also taken care of. How do the beta blockers help? You said esmolol. Is patient ko OPD mein esmolol dena hai?
Ma'am, propranolol hai. Ma'am, this patient is already on
esmolol kyun bola?
Ma'am, I can.
You have this patient which we are discussing who's come in the OPD, is to be stabilized and managed, made euthyroid, and then got for surgery. It's not an emergency surgery. So फिर esmolol क्यों बोलना है? ठीक है? So propranolol. How does propranolol act? What is
Ma'am, it gives symptomatic relief of tachycardia and hypertension and rhythm abnormalities. And on top of that, it also inhibits peripheral conversion of T4 to T3.
So it takes care of the sympathetic output related features, and it prevents the peripheral conversion of T4 to T3. Okay. So you'd like to put the patient on methimazole. You'd like to put the patient on propranolol. Anything else?
Ma'am, I can also give corticosteroids like dexamethasone.
Why do you want to put the patient on dexamethasone in the OPD?
I'm not in the OPD.
Please don't confuse two things. This patient has come to you in the OPD, needs to be put on therapy, sent back home. For how long? When will you want her back?
Ma'am, 6 to 8 weeks.
Okay, so approximately 6 weeks is required for the euthyroid status to be achieved. So you send her back on methimazole. For all the students listening in, please, all antithyroid drugs must be read carefully. Read the mechanism of action, read where in the thyroid cycle these drugs act, the dose of these drugs to be given, and the complications that is there with each drug. What is the major complication that you see with these antithyroid drugs like methimazole or carbimazole?
Ma'am, agranulocytosis, vasculitis.
So agranulocytosis, vasculitis, anything else?
Ma'am, propyl thiouracil has teratogenicity.
They also have some amount of hepatotoxicity, which means that they can increase, you have features of raised alkaline phosphatase, jaundice, and hyperbilirubinemia can occur in these patients. So sometimes hepatitis may also be precipitated. So hepatic involvement, vasculitis, agranulocytosis is commonly seen. So all antithyroid drugs need to be read in detail. Please, all the dosages, where they act, and all the side effects must be known to you. Okay. So you will put this patient on propranolol. You will put this patient on methimazole or carbimazole and request the surgeon to wait for the euthyroid status to be achieved. Call the patient approximately after 6 weeks. Is that okay?
Yes.
Okay. Now, The patient has come to you after 6 weeks. Her free T3, T4 are normalized. Her TSH is okay. Her hemoglobin is now approximately same 9.2. The rest of the investigations are all within normal limits. Now, will you accept her?
Yes, ma'am.
Okay. What problems do you think will now occur when you are accepting this patient and you plan to anesthetize her? She has a large multinodular goiter sitting there for 12 years. Although her euthyroid status has been brought to normal. I mean, thyroid status has been made euthyroid. What problems do you anticipate with a large thyroid swelling?
Ma'am, there can be, ma'am, ma'am, you're asking me the
what problems you are going to anticipate when you plan your anesthesia? Is she going to create any trouble for you?
Yes, ma'am, there can be chances of a thyroid storm in the perioperative period. There are concerns related to positioning, concerns related to my patient does not have exophthalmos, but
okay.
But that
else which is more important before you've come to thyroid storm and exophthalmos, is she likely to have a difficult airway?
Yes, ma'am.
Okay, so a large goiter, whether it's a multinodular goiter or a cascade or a long-standing papillary carcinoma or a large goiter which has got compressive symptoms, are all conditions where you are anticipating a difficult airway. So
yes,
when the doctor asks you the concerns in anesthesia or problems that you anticipate, you should be able to identify and enumerate all these. So this is a patient who's likely to have a difficult airway.
yes,
she's a patient who will have problems related to hypo or hyperthyroidism if it's not well controlled, which means she can have a thyroid storm, or she can be on the hypothyroid side intraoperatively and postoperatively if her condition is not controlled. The thyroids, large thyroids or large multinodular goiters will have concerns related to bleeding, concerns related to positioning, and a higher chance of developing postoperative complications, which we will come to as we move forward. Okay, so all these are the concerns of anesthesia. Now, what in the airway is likely to be difficult? Airway difficult is a very broad term. You've had a very detailed examination of the airway. What in her airway is likely to be difficult and why?
Ma'am, the mask ventilation and intubation insertion of the ET tube can be difficult.
Okay, so she will have, you have that algorithm. If you read the textbooks or read the articles, AMF or Airway Management Foundation, we published an article a couple of years back where a detailed line of sight examination, even in the DAS guidelines and the difficult airways, other societies, you have a detailed examination of the airway and identification of the place where it will be difficult, which means that whether consent and cooperation will be difficult, whether the mask ventilation will be difficult, insertion of supraglottic device, insertion of laryngoscope, intubation, emergence or extubation, and lastly, whether the surgical access will be difficult. So in this patient, if there's a large goiter which prevents you from holding the mask well, there'll be difficulty in mask ventilation. But a supraglottic device insertion may not be difficult. Laryngoscopy may or may not be difficult depending upon the size. If it's a large thyroid, the laryngoscopy will also be difficult. If there is compression and deviation of the trachea, or there is some amount of intratracheal extension of the tumor, or it's a retrosternal goiter, then intubation will also be difficult. And most importantly, the surgical access will be difficult. It's very difficult to identify the cricothyroid membrane in a large goiter. Emergence will also be a problem. So all these issues are difficult in this airway. Okay, and already we've identified the other problems of anesthesia in this patient. Now, what pre-op orders will you give? And how will you prepare this patient for surgery? She's electively come to you for a subtotal thyroidectomy.
Ma'am, nil per oral for 8 hours, written informed high-risk consent, then arrange blood and blood products, then anxiolytic tab alprazolam 0.25 mg on the night before surgery.
Was hyperthyroid and she still might be a little anxious. You would like to give her an anxiolytic.
Anxiolytic. Yes,
Yes.
ma'am.
So you are saying you'd like to give Alprax 0.25 milligrams HS and on the day of surgery with a sip of water.
Ma'am, I will arrange blood and blood products. Then I will ask the patient to continue anti-thyroid medications and propranolol till morning of surgery.
Okay, so when you mention this, beta, for all your cases, not only this, please mention specific drugs, the dose and the time. So don't just say, I will give Alprax. You mention, I will give Alprazolam 0.25 milligrams at 6 a.m. with a sip of water, or whatever anti-thyroid medication she's taking. I would like her to take her methimazole, these much milligrams by mouth at 6 a.m. with a sip of water. Okay, goes true for all your cases. When you say, I want to give the cesarean section perinorm or metoclopramide and ranitidine, please mention how much, by what route and what time. Okay, so you're going to advise her to continue her antithyroid medication, including propranolol and her methimazole on the morning of surgery, to take alprazolam in the night and morning 6 a.m. or 7 a.m., whichever is about 2 hours prior to surgery. In the morning, nilpar oral. Would you like to do a basal heart rate monitoring? We left that out because she's hyperthyroid. So I would like you to do the night before surgery a resting heart rate so that we can detect any resting tachycardia if it's there. So monitoring of the basal sleep heart rate must be done. Okay. Anything else? Would you like to give her any sedative pre-medication on the morning of surgery other than this alprazolam?
No, ma'am.
Okay, so you must be careful if the examiner is asking you this question. What he wants to ask you is whether you would like to prescribe any sedative pre-medication in an anticipated difficult airway. So if you feel that it's a large thyroid, or the situation is such that the examiner is asking you a large thyroid with compressive symptoms, a retrosternal extension with difficult airway, please be cautious in advising sedative. It can be given. It's not that it can't be given, but it has to be given under monitoring in small dosages. Okay, this is what he wants to hear from you. Okay, so anxiolysis you will give, sedative pre-medication probably you want to avoid in this patient. Okay, now morning of surgery, she's come to you, you've done all this, she's euthyroid, you've had all the investigations, she's come to you. How will you induce anesthesia? You've given pre-op orders. How will you induce anesthesia and manage her airway? If we are considering that she's got a large multinodular goiter and we have deemed that it's a difficult airway, what is your plan of anesthesia and how will you proceed?
Can you repeat? You have established that it's a deemed?
It's been deemed a difficult airway. It's now an established difficult airway. How would you plan your anesthesia and proceed?
Ma'am, my plan of anesthesia is general anesthesia with controlled mechanical ventilation with the help of a flexometallic ET tube. Ma'am, I would initially like to do, since it is a difficult airway and a large mass, I would initially like to do a video laryngoscopy. And if that turns out to be difficult, awake fiber optic intubation.
You can't have awake fiber optic intubation as a plan B fallback. Would you like to plan her initially? Because I've said she's got a large multinodular goiter with compressive symptoms. She's likely to have a difficult airway. Can you plan her for an elective awake fiber optic as a plan A?
Yes, ma'am.
Okay. So let's start with, let's see that if she can be planned for a fiber optic awake nasal intubation and proceed further. Okay.
Yes.
So this is her plan. You discuss with your consultant. She says, plan her for an awake fiber optic. What all will you do and how will you start?
Ma'am, first of all, I will ask for consent and then I will explain the patient, the process to the patient thoroughly. And then in the preoperative room, I will give her injection glycopyrrolate 0.2 mg 30 minutes prior to the surgery. And then I am. Please be careful when you prescribe a drug that has significant effects on the heart rate. Okay, remember,
that atropine is not to be given. Glycopyrrolate is the only drug, that also IM, because it's going to produce a lot of tachycardia. It may not produce as much tachycardia as atropine does, but still it may have an effect on the heart rate. So be careful and monitor these patients when you give them glycopyrrolate. She's hyperthyroid. She was hyperthyroid, okay? Although now her thyroid status is controlled. So be cautious when you give glycopyrrolate, okay? So IM glycopyrrolate 30 minutes to 1 hour prior to the planned procedure. IM in
yes,
the block holding room.
Yes, ma'am.
What else?
And then I would like to nebulize her with 4% lignocaine.
Nebulization से कुछ करना है?
Yes, ma'am.
Nebulization से पहले कुछ करना है? Do you want to do anything before you nebulize?
Also,
Prepare the nasal.
cotton in ligno with. Yes, ma'am. Yes, ma'am. I would like to soak cotton balls in ligno with lignocaine, 2% lignocaine with ADR solution, and I can also put xylometazoline drops in each of the nostrils.
Okay. What nerves will it anesthetize? So your nasal preparation is for decreasing the vascularity, because if you have a nasal bleed, your entire fiber optic is going to go for a 6. So you need to prepare the nostril. First, you need to see for nasal patency. Okay. You will intubate through the more patent nostril. And you need to prepare by putting xylometazoline or oxymetazoline drops. As you've said, you'll soak pledgets with 2% xylocaine with adrenaline and put them into the nasal cavity. Now, what nerves it anesthetizes when you do this in the nose? That means you must know the nerve supply of the nasal cavity, including the ethmoids as well as the nasal septum. So the greater and lesser palatine nerves and the anterior ethmoidal nerves are the ones which will be anesthetized when you put these pledgets soaked in lignocaine with adrenaline. Next, you say you want to nebulize. क्या करना है, कितना करना है?
Ma'am, 4% lignocaine, 2 ml. I will nebulize the patient.
4% lignocaine, 2 ml will be enough to nebulize an adult patient. You may need a little more. You may need 4 to 5 ml to nebulize. Okay, so 4% lignocaine can be nebulized. Which nerves will this anesthetize?
Ma'am,
what I want to know is what is the nerve supply of your upper airway?
Ma'am, upper airway, it'll superior laryngeal nerve above the vocal cords.
So we've just said we want to anesthetize the nose, which anesthetizes the greater and lesser palatine and the anterior ethmoid. Then we come down and the glossopharyngeal needs to be anesthetized. So your nebulization is also going to affect the glossopharyngeal nerve. What does the glossopharyngeal supply? It will supply your posterior 2/3 of the tongue up to the vallecula, the lateral pharyngeal wall, and it will supply the upper surface or anterior surface of the epiglottis.
Yes.
So the lower surface of the epiglottis is by the
superior laryngeal nerve above the vocal cord.
So the aryepiglottic folds, the arytenoids, and the posterior surface of the epiglottis is by the superior laryngeal nerve. The surface below the vocal cord is by the recurrent laryngeal nerve. This all from the top to the bottom you must know. And what procedure you will do to anesthetize these nerves. That means when you soak pledgets and put them in the nose, it anesthetizes these nerves. When you nebulize the patient, it will take care of the glossopharyngeal and probably some part of the superior laryngeal. The inferior laryngeal can only be anesthetized if you have a transtracheal injection of the drug. Okay. The other thing which you can do besides nebulization is you can ask the patient to gargle. You can take 2% viscous lignocaine and give a few swishes to the patient, ask them to keep it in the mouth and then throw it out. Okay. So nasal preparation, nebulization with 4% and gargling with 2%. Gargling is especially useful because it takes care of your gag reflex, which means the glossopharyngeal is taken care of. The pulmonary wall, uvula, the epiglottis superior surface is all taken care of. Okay, and then the remaining part of the superior laryngeal and the recurrent laryngeal can be anesthetized by the spray as you go technique. But in all this, you must remember what is the total dose of lignocaine that is allowed in any patient. What is the maximum dose?
Ma'am, for topical anesthesia, it is 9 mg per kg.
Okay, the current textbooks mention 9 mg per kg. The previous textbooks mention 7 mg per kg with adrenaline. Okay, so when you do all this, you must know how much of total adrenaline you are giving to the patient so that you don't exceed the toxic dose. When you nebulize, कितना absorb होता है और कितना नहीं होता? आपने 5 ml nebulize किया, उसमें से कितना absorb हुआ?
25%, ma'am.
So 25% of this which you nebulize is absorbed, and you can calculate if you have a dose of 7 to 9 milligrams, 7 milligram or 9 milligram per kg as the maximum dose. With 7 milligram per kg, this actually turns out by a formula approximately 0.35 ml per kg of a 2% solution. The standard 2% solution with adrenaline which you have, which has 20 milligrams of lignocaine per ml, to reach this maximum dose, 0.35 ml per kg, which turns out to be approximately 21 ml for a 60 kg adult. Okay, so when you know that you can give only maximum 21 ml of 2%, you can divide it into various parts and see that when you do these things, you do not exceed the maximum dosage. Okay, so you prepare the patient by preparing the nostril, then you nebulize the patient. You can also ask the patient to gargle, and the remaining part can be taken care of with spray as you go technique. Okay, when you take the patient for an awake fiber optic, as you've said, I will give the patient some amount of glycopyrrolate. Would you like to give some sedation also when you take the patient on table?
Ma'am, but I can give, but I'll have to be careful about it. Yes.
Yes, which would you like to give? Because he will not let you do an awake fiber optic without sedation.
Ma'am, injection midazolam 1 mg. Ma'am.
How much? And
1 mg.
1 mg IM, IV?
IV.
1 mg midazolam IV can be given. What else can be given if the patient is a little uncooperative?
Ma'am, injection fentanyl.
20, how much?
20 micrograms.
You want to give by per kg body weight or randomly just 20 for any patient?
Ma'am, by per kg body weight, but I would have to give it in titrated doses, ma'am, because I can't.
Be given. So 0.5 to 1 microgram of fentanyl can be given together with 1 milligram of midazolam. Is there any alternative to this drug? Instead,
dexmedetomidine can also be given.
A very good drug for awake fiber optic because it not only produces sedation, anxiolysis, also produces some amount of anterograde amnesia, and produces a stable cardiovascular status because it takes care of the sympathetic output. So dexmedetomidine in a dose of 1 microgram per kg as a loading dose, together with 0.5, say up to 0.3 to 0.7 micrograms per kg per hour can be started as an infusion. And this can allow you to do a fiber optic intubation in an awake state with all this local preparation. Okay, now which tube, endotracheal tube would you have selected?
Ma'am, a flexometallic tube, ma'am.
Okay, it's a little difficult to negotiate the flexometallic over a fiber optic scope, but of course with experience it can be done. Suppose this was not a large multinodular goiter, it was an ordinary goiter with no compressive symptoms, no airway problems. Would you have induced anesthesia in any different way?
Ma'am, I can give, ma'am, I can insert a flexometallic tube orally.
Okay, so routine induction of anesthesia can be done with an IV inhalational agent like you normally do, and you can then say that because you can use a video laryngoscope to visualize the glottic opening and intubate the trachea. Would you like to use thiopentone or propofol?
My patient is euthyroid, I can use propofol.
Yes, absolutely.
But thiopentone is also preferred.
Both thiopentone as well as propofol. Okay, so you can do a video laryngo. Now, suppose this patient was not very well prepared, and you came in, and the patient, you did not assess the patient well. She had a large thyroid. You induce anesthesia, and you cannot mask ventilate. ठीक है, पेशेंट आया, पेशेंट को आपने टेबल पे रखा, आपने उसको थायोपेंटोन दे दिया, ठीक है, वो एपनिया में चला गया, and now you can't mask ventilate. There was a large thyroid and you didn't assess it well. You started with IV induction. Now you can't ventilate. अब क्या करना है?
Ma'am, I will ask someone to manually lift the thyroid for me.
Okay, so if there is a collapse of the airway after induction of anesthesia, the large thyroid is preventing mask ventilation, so preventing the air from going in. So somebody can manually lift the trachea off the trachea and allow you to ventilate. Can you insert a supraglottic device? Will it help? Mouth opening to theek thi, supraglottic device bhi dal sakte the. Why can you put a supraglottic device for ventilation here?
Ma'am, a supraglottic device cannot ensure that the tracheal compression is
for upper airway involvement, supraglottic device will help well. But where the problem is at the tracheal level, where this compression of the trachea because of the large thyroid, use of a supraglottic device will not help. So here you have to manually lift the thyroid off the trachea, and a supraglottic device at this point will not help. Okay. What are the problems with positioning? Now that you've intubated the trachea, the anesthesia has been induced. Any problems related to positioning, which you will be thinking about?
Ma'am, the patient will be positioned in an extension position. So since I'm using a flexometallic tube, there could be chances of tube migration.
Okay, what else? So with
ma'am,
since we are running short of time, with an extreme positioning, when there is extension, make sure that the head and neck is supported well. The cervical spine is supported well. There is a potential for the flexometallic tube or any other tube that you put in to come out. So fix the tube well. Make sure that the eyes are padded well, particularly if there is exophthalmos. The tube is secured well. The machine is usually pushed away, and the arms should be secured alongside the patient. They should be adducted, and you should have extension lines so that a delivery of drugs through the IV line is not interrupted once the patient is clean, draped, and handed over to the surgeons. So positioning is an issue, okay? Any specific drug you would like for muscle relaxation?
Ma'am, I can use vecuronium in this patient.
Okay, you can use any drug which does not cause sympathetic stimulation. That means pancuronium is out. The rest of the drugs are standard and can be used. We'll just have another 5 minutes while we finish up. Now, at the end of surgery, would you like to do anything prior to extubation? It's been a large multinodular goiter. The surgeon has spent 3 hours in dissection and wants you to see the vocal cords prior to extubation.
Ma'am, this is a long-standing, ma'am, this is a long-standing goiter. So I would like to ensure vocal cord movement. I will first do a Bailey's maneuver. I will insert a LMA behind my tube.
Absolutely, a Bailey's maneuver can be done. It's very difficult to see the vocal cords when the patient is coming out of anesthesia and the neuromuscular blockade has been reversed. You cannot put a laryngoscope and see the cords. So if your cords need to be seen, then you can do what is known as Bailey's maneuver, in which a supraglottic device is put behind the endotracheal tube. Then the circuit is shifted on to the supraglottic device for ventilation. The neuromuscular blockade can be reversed. And then you can put in a fiber optic through the supraglottic device and remove the endotracheal tube under vision, and remove an endotracheal tube under vision while the patient is being ventilated with the supraglottic device. It takes care of also a stomy extubation. Then you can slowly bring the patient out while the patient is breathing on the supraglottic device. So please read Bailey's maneuver, and videos are available on YouTube for you to see the Bailey's maneuver if you've not seen it at work. What postoperative complications are likely to occur in this patient?
Ma'am, the immediate postoperative complications are laryngeal edema, hematoma, stridor, tracheomalacia,
Okay.
and thyroid storm.
Okay, so any of these complications can occur, particularly if the patient has not been well prepared. How would you recognize a thyroid storm postoperatively?
Ma'am, confusion, agitation, seizure, raise in body temperature, hypercarbia, raise in EtCO2.
Rise in body temperature, tachycardia, sweating are characteristic features. Diaphoresis, okay? Then you can have tachycardia, palpitations, dysarrhythmias, failure. All these features can be present, because we'll not go into the details because Dr. Sheetal will anyway cover the management of a thyroid storm. But if the patient develops any of these features in the postoperative period, please keep a differential diagnosis of thyroid storm, and you should know how to treat a thyroid storm in the postoperative. What are the cornerstones of therapy?
Ma'am, we would like to do symptomatic management. Initially, we will increase the oxygen to 100%, and then we will give cold glucose-containing IV fluids. Ma'am,
treatment for increase in temperature, cold IV fluids, cooling blankets, beta blockers, corticosteroids, and antithyroid drugs. Okay, sometimes you may like to control the size of the thyroid with the use of supersaturated solutions of potassium iodide. 5 drops of the solution can be given by mouth at 8-hourly intervals. But remember to start antithyroid drugs before you start the supersaturated solution of iodine, because that will initially provide more iodine for hormone synthesis, and release of hormone will increase. So start the antithyroid drugs and then start potassium iodide. Give steroids in the form of dexamethasone 2 milligrams every 8-hourly. Give antithyroid drugs like propylthiouracil by Rylstone, and give the patient all symptomatic therapy. And esmolol here can be given for control of heart rate. Okay, so thyroid storm is one complication that can be managed. Other complications like tracheomalacia can be managed at the end of a surgery. If you suspect that there is tracheomalacia in these patients, you can not extubate on table. It can be a planned thing. You can have a tracheostomy electively, or you can keep the patient intubated for a couple of days and then extubate on an exchange catheter in the ICU. The tracheomalacia will be taken care of after a few days because of fibrosis that occurs. The trachea will get supported. So tracheomalacia, respiratory distress, hypocalcemia because of removal of the parathyroid glands are all complications that occur in the post-op. What we've not discussed, one thing, is pain relief in these patients. So prior to shifting the patient out at the end of the surgery, would you like to ensure pain relief by some method?
Ma'am, I can give NSAIDs. I can.
What is NSAIDs?
Ma'am, non-steroidal anti-inflammatory agents.
Okay. Anything else?
Ma'am, I can also give a cervical block.
Have you ever given one? Okay, so deep and superficial cervical plexus blocks are commonly given for post-operative pain relief. I commonly give a bilateral superficial cervical plexus block. Please read the nerve supply, what all is blocked. C2, C3, C4 is blocked when you give a superficial cervical plexus block. The place where it's given, how it's given, how much drug is inserted. It's given at the posterior margin of the sternocleidomastoid muscle, and in a fan-shaped manner. You can inject about 10 ml of lignocaine on one side to ensure complete analgesia of the incision site. So otherwise, if you don't want to give this, deep cervical plexus block has many complications and is not commonly preferred. In the textbooks, it's also written that you can give a cervical epidural for although it's not very commonly done, but for completion's sake, a cervical epidural, a deep cervical, a superficial cervical plexus block can be given. You can have local infiltration with local anesthetics together with paracetamol can be given in the postoperative to take care of the pain. Okay, we've already discussed how to manage tracheomalacia. Electively, an intubation can be carried out, or electively a tracheostomy can be done when you have a tracheomalacia which you are suspecting. Now, suppose this patient lastly comes for an emergency surgery. Suppose the patient who had come to you initially, that patient which you saw in the PSC with raised thyroid hormones, she has a RTA in the evening and comes to you with hemoperitoneum. Will you accept her for surgery or not?
Ma'am, it's an emergency surgery. I will have to accept her.
At that time, how will you plan your anesthesia?
Ma'am, general anesthesia with controlled mechanical ventilation with a flexometallic tube, and I will induce with thiopentone. I will.
Is there any other tube which you can put? Suppose you did a laryngoscopy. Could you put any other tube besides?
Ma'am, I can use an orth pole, but then I'll have to insert it nasally.
Yes, you can do an RAE tube, you can have a flexometallic tube, or you can occasionally also use a normal PVC tube if there is no increase in the size of the thyroid or you're not expecting a difficult airway. So how would you have prepared this patient if she would have come for an emergency surgery?
Ma'am, I will give her propyl thiouracil through a Ryle's tube, 400 mg. And then I will give her 40 to 60 mg of propranolol for
emergency surgery. She has a hemoperitoneum and she needs to be taken stat. Would you like propranolol, or this is the time when you would like to give her esmolol?
I can give her esmolol and ensure the heart rate is below 90.
90. So 90 is the cutoff heart rate. Give her esmolol and reduce her heart rate to about 90. Give her hydrocortisone. Give her propyl thiouracil, and then prepare the patient and be prepared for an emergent thyroid storm in the postoperative period.
Yes, ma'am.
So any other questions that you have? The remaining theoretical part, Dr. Sheetal is waiting in the wings to complete the discussion. Is there any question which you wish to ask, or if there's anything in the chat box we can take later? We'll let Dr. Sheetal finish her presentation and then we'll move further. Thank you so much, Sandra.
Thank you, ma'am.
Over to you, Sheetal.
Thank you, ma'am. It was very informative lecture. You have covered most of it. I just have to summarize only. Slides. Good afternoon, everyone. Ma'am has covered almost everything. Nothing much is left for me, but still I'll try to rapidly summarize it. I'll be discussing thyroid gland and anesthetic management of large thyroid mass. So thyroid gland is a H-shaped gland present in the neck. It has a right-left lobe with the isthmus. It lies anterior to trachea, just below the cricoid cartilage, covering second to fourth tracheal ring, and is approximately 20 grams. These are the systemic uses, why we need thyroid hormone. These are the uses of the thyroid hormone. Ma'am has covered all of these system-wise, so I would like to skip as there is shortage of time. This slide shows the synthesis of thyroid hormone and the effect of various drugs on the different steps which they block. Like in this, oxidation is blocked by thioamides, then organification is blocked by iodides and thioamides both, and then peripheral conversion is blocked by iodine, contrast beta blocker, amiodarone, thioamides, thiopentone, and steroids. Now, normal value of thyroid hormone might be asked in exam. Normal value of thyroid stimulating hormone is 0.5 to 5 milli international unit per liter. Normal value of thyroxine is 0.7 to 1.8 nanogram per deciliter. Sometimes you might find it in picomoles also. Then the normal value is 9 to 23 picomoles per liter. Normal value of triiodothyroxine, thyronine is 0.2 to 0.5 nanogram per deciliter. Please look for the values clearly. Now, coming to hyperthyroidism, whenever you get a case of hyperthyroidism, goiter with hyperthyroidism, eye signs is one of the favorite questions for the examiners. So this is a summary of the eye signs. Rosebeck sign, there is in this there is tremor on closed eyelid. In Stelweck sign, patient has a staring look with infrequent blinking. In Delry-Empel sign, sclera visible between the cornea and upper lid. In von Graefe sign, there's lagging of the upper eyelid when patient look downwards. Geoffroy sign, there's loss of forehead wrinkle on looking up. In Moebius sign, there's lack of convergence. Now coming to treatment of hyperthyroidism, it takes usually 6 to 8 weeks to make patient euthyroid. It can be done by using antithyroid drugs that includes propylthiouracil, methimazole, and carbimazole. Doses are given. Then for symptomatic relief, we would like to use beta blockers. Non-selective beta blockers are preferred over selective beta blockers, and as they provide better control of tachycardia, and they also block the peripheral conversion of T4 to T3. And propranolol is the preferred agent. If you, as this patient is for elective surgery, we would like to start her on propranolol 40 to 80 milligrams, 6 to 8 hourly. Now, other agents which can be used is radioactive iodine, but this is only used in relapse cases or where antithyroid medical therapy fails. Before starting this, antithyroid drug should be stopped at least 3 days prior to starting the radioiodine therapy. Post-therapy, patient might develop hypothyroidism, and it is not recommended for use in pregnancy because of obvious reasons. Now, definitive treatment is surgical. It is indicated only when there is large toxic multinodular goiter, solitary toxic adenoma, failed medical therapy, or underlying carcinoma. Now, to treat hypothyroidism, it also takes 6 to 8 weeks to make patient euthyroid. Oral thyroxine is started, and it is gradually increased to attain a euthyroid state. In elderly patient with CAD, the starting dose is lower than the conventional starting dose. Now, what is goitre? It is an abnormal enlargement of thyroid gland that results from compensatory hypertrophy and hyperplasia of follicles due to decrease in thyroid hormone. Functionally, most of these patients are euthyroid. Now, what are the problems you anticipate in these patients? The mass effect due to large goiter may impact structures which are present in the neck. What are the structures? It is our airway, esophagus, and nerves. Now, if there is a retrosternal extension, then structures in the thorax may also be affected. So our major concern is airway issue beside hyper and hypothyroid status of the patient. So what are the pre-investigations and pre-anesthetic checkup has been well covered by ma'am. I'll just directly go to pre-op orders. Written informed high-risk consent and consent for post-operative mechanical ventilation and tracheostomy is to be taken if patient has a long-standing goiter, which is very large in size. Explain awake fiber optic intubation if it is planned. Pre-medicate the patient. Anxiolysis is given in patient without any airway compromise. Arrange adequate blood and blood products. No sedation is to be given in patient who are showing symptom of airway compromise. Now, in hyperthyroidism, we need to continue the antithyroid drugs and beta blocker till the morning of the surgery. Similar in hypothyroidism, we need to continue thyroxine till the morning of the surgery. In hypothyroidism, anti-aspiration prophylaxis is also very important as they have delayed gastric emptying. Sedation is to be used cautiously in hypothyroid patient because they are prone to drug-induced respiratory depression. What is your anesthetic plan? It is general anesthesia with endotracheal intubation. And if it is a large mass, you can plan awake fiber optic intubation with bilateral, superficial, and or deep cervical plexus block. And cervical epidural can also be used, although it is rarely used. Now, this is the algorithm. How will you manage this patient? As we have already discussed during the case discussion, you can get to know, you need to see whether there is a tracheal deviation present or not in the X-ray, and you will get to see that in CT also. If it is absent, then conventional intubation can be done. If it is present, then we will look for retrosternal extension and tracheal compression. If both are not present, then we can go for routine conventional intubation. If there is retrosternal extension is not present, but compression is present, then we need to investigate further. using fibroscopy or CT scan to delineate the extent of compression. If the compression is more, definitively there, it's significant compression is there, then we should go for awake fiber optic. If there is retrosternal extension present, but there is no tracheal compression, then we can go for inhalation induction followed by fiber optic intubation. If both are present, retrosternal extension is also there and compression is also there, then we should always go for awake fiber optic intubation only. What are the tubes that you are going to use? We use reinforced or flexometallic endotracheal tube, as it is less likely to kink. Conventional endotracheal tube, that is PVC tube, they get kinked, so we don't prefer to use them. Other tube that can be used is RAE, North Pole endotracheal tube. It keeps the breathing tube away from the surgical field. You should keep small size tubes also ready in case there is a tracheal compression. Now, during induction, what you need to keep in mind in hyperthyroid patient, avoid drugs that increase the sympathetic activity like ketamine and atropine. Propofol can be used as our patient was euthyroid, but their volume of distribution is increased in hyperthyroid patient. Achieve adequate depth of anesthesia prior to intubation or any surgical manipulation. Avoid indirect acting sympathomimetic drugs like ephedrine for hypotension. If it occurs intraoperatively, we should go for directly acting vasopressors like phenylephrine. Nitrous oxide and opioids are safe to be used. What need to be seen in patients who are hypothyroid and we are inducing those patients? Ketamine or etomidate may be the induction agent of choice. Patient may be more sensitive to hypotension. Hypotensive effect of the anesthetic drug because they have reduced cardiac output, blunted baroreceptor reflexes, and decreased intravascular volume. We need to titrate our anesthetic drugs in these patients. Now, if there is an intra-op hypotension during the surgery, then ephedrine is the drug of choice. But if patient does not respond to ephedrine, we might have to use dopamine and epinephrine. Now, positioning of the patient. Patient is positioned with head extended by placing a sandbag between the shoulder blades. Headrest is padded with horseshoe or whitlock headrest, and neck is supported. Head end of the table is lifted up. For eye protection, we need to cover the eye, especially in patient with proptosis. Hands are adducted, so we would require an IV extension line. What monitoring would you like to do? Standard ASA monitoring, including the temperature monitoring, which is very important and crucial in these patients. Neuromuscular monitoring can also be used. Invasive arterial monitoring and central venous pressure monitoring is specifically done if it is individually required. Otherwise, it's not routinely practiced. Electrophysiological monitoring of recurrent laryngeal nerve can be done if it is available. Intraoperative concerns in hypothyroid patient, they have decreased neuromuscular excitability, which is exacerbated by our anesthesia drugs. All the non-depolarizing muscle relaxant like vecuronium and tracurium are generally safe. We just need to use a peripheral nerve stimulator for monitoring of muscle relaxant. There is increased sensitivity to volatile anesthetic in hypothyroid patients. They are also more prone to hypothermia, electrolyte imbalance, and hypoglycemia. So early blood sugar monitoring should be done in these patients. Extubation and emergence may be delayed due secondary to hypothermia, respiratory depression, or slow drug metabolism. In hyperthyroid patient, we should keep in mind that we maintain adequate depth of anesthesia, and analgesia should be adequately maintained by supplemental opioids. Isoflurane, sevoflurane, both can be used. There is no significant increase or decrease in MAC values of both of them. Now, coming to pain management, we prefer a multimodal approach for these patients. Opioids should be used judiciously in hypothyroid patient and adequately in a hyperthyroid patient. Non-steroid anti-inflammatory drugs can also be used. We can use a USG guided superficial cervical plexus block. Local infiltration can also be done. Now, coming to reversal and extubation, ensure a complete reversal of neuromuscular blockage. How will you assess the vocal cord movement in these patients? although it is mentioned you can use direct laryngoscopy, but it is not conventionally done. We use either video laryngoscope or nasal fiber optic, but best is Bailey's maneuver as explained by ma'am. Observe the patient on table for after extubation for stridor or any airway obstruction. Now coming to post-operative complication of thyroid surgery, there can be early or late complication. Early complications include hematoma, laryngeal edema, nerve damage, tracheomalacia, thyroid crisis, pneumothorax in cases who have retrosternal goitre. Late complication include hypoparathyroidism, hypocalcemia, and hypothyroidism. Hematoma incidence is 0.3 to 1%, but it can be fatal. Majority occur within 6 hours. Symptoms are neck swelling, dyspnea, stridor. It is acute emergency. There is acute airway obstruction, and we might end up in can't intubate, can't ventilate situation. Immediately remove the sutures, and patient should be intubated, and re-exploration should be planned. Patient should be shifted to OR for definitive hemostasis. Now, laryngeal edema, it may also occur because of traumatic tracheal intubation or the large hematoma or too much surgical manipulation. Patient, this leads to stridor and airway obstruction, may require re-intubation. A smaller size ET tube, video laryngoscope, and fiber optic scope should be kept ready. Now coming to nerve injuries, recurrent laryngeal nerve is the most common nerve injured. It might injure due to traction, transaction on entrapment or ischemia. It can be transient or permanent, unilateral or bilateral, partial or complete. This is a very important slide. This you should understand properly. Now, injury can be unilateral or bilateral. First, I would like to tell if there is a partial unilateral injury, in any recurrent laryngeal nerve partial injury, the abductor fibers are the first to go. There is an unopposed adductor action. So as we can see in this picture, there is a unilateral partial injury. Because of unopposed adductor action, the vocal cord lies in the midline, and this is the position during inspiration. Patient is able to inspire, but during phonation, there is hoarseness of the voice. This will be the position of the vocal during phonation. While in complete paralysis, both abductor and adductor both are gone. So the vocal cord will be in paramedian position or cadaveric position. In this will be the position of the vocal cord in inspiration, and this in phonation. Initially, patient will have hoarseness in phonation, but gradually it improves as the opposite vocal cord overcompensate and hyperabduction is seen. In bilateral palsy, if bilateral partial is the most dangerous palsy, as both the abductors are gone, both the vocal cords lie in midline, and this is an emergency situation, and patient will come with stridor, and we need to tracheostomize the patient as soon as possible. In bilateral complete palsy, patient is able to breathe. He will not be able to phonate, but he will be able to breathe. So it is not an emergency crisis situation like a partial bilateral injury. Now coming to tracheomalacia, it is generally seen as in large size, long duration goiter leading to prolonged compression of the trachea. How can we see it preoperatively before extubation? We do a cuff leak test. Cutoff value for a leak volume is 110 ml. If the leak is more than 110 ml, then we presume that there is no tracheomalacia. If leak is less than 110 ml, lesser the leak volume, higher are the chances of post-extubation stridor. We can also plan a fiber optic examination before extubation to see the collapsibility of trachea with inspiration. Extubation on an airway exchange catheter is to be done to facilitate re-intubation. Now coming to thyroid storm, rare nowadays because of widespread use of anti-thyroid drugs and beta blockers. It can occur in complete perioperative, pre-op, intra-op, and post-operative period. In post-operative period, it can occur up to 6 to 48 hours post-operatively. Mortality rate is 20%. Now, what are the clinical presentation under anesthesia and in awake patient? Under anesthesia, we'll see a sudden increase in EtCO2 and soda lime exhaustion, tachycardia, hypertension, arrhythmia, and patient might have congestive cardiac failure. There is increased bleeding due to hypertension. Now, in awake patient will complain of increased sweating, dehydration, tachycardia, tachypnea, delirium, seizures, coma, restlessness, extreme irritability, vomiting, and abdominal colic. How will you manage this patient? If patient is under anesthesia, immediately 100% oxygen should be started, deepen the plane of anesthesia, IV administration of glucose-containing crystalloid should be done, and symptomatic relief should be done using ice pack and cooling blanket to decrease the temperature. If atrial fibrillation is present, beta blockers or digitalis can be used. And if only tachycardia is there, beta blocker are titrated to decrease the heart rate to less than 90. An anti-thyroid drug, propylthiouracil 400 milligram etali to be given through nasogastric tube if under anesthesia, and orally if patient is conscious. Steroid to be given either dexamethasone 2 milligram 6 hourly or hydrocortisone 200 milligram 8 hourly. If patient is in circulatory shock, IV administration of directly acting vasopressors like phenylephrine is to be used. Now, hypoparathyroidism occurs mostly due to devascularization of parathyroid gland or trauma during the surgery or accidental removal of the parathyroid gland along with the thyroid gland. Signs and symptoms suggestive of hypocalcemia occur 24 to 48 hours postoperatively. Initial neurological presentation is paresthesia of perioral region, hands, feet, cramps, hyperreflexia, muscle spasm, positive chopstick sign, Trousseau sign, hypocalcemic stridor, laryngospasm, or convulsion. Treatment is IV calcium gluconate followed by oral calcium and vitamin D supplementation. Thank you.
Thank you, Sheetal. Thank you so much, Sheetal. That was a very comprehensive synopsis of the topic. Thank you, Sandra, for the presentation. If there are any questions in the chat box, Dr. Nitin might help us. Questions, Nitin?
There are no questions.
No questions.
Thank you so much.
Thank you so much, ma'am.
Thank you so much, ma'am. And thank you, Sheetal, for the wonderful summary of the case. Thanks a lot for your valuable input to APPEC2023 and for being a part of APPEC2023. It's always a pleasure having a case discussion headed by you, ma'am. So, absolute pleasure. We'll quickly go for the lunch break, for the quiz. So can we have the questions? Yeah. So the first question is resuscitation guide and protocol tool for mortality in sepsis. Options are A, the central SCVO2. Option B is mean arterial pressure. Option C is lactate levels. And option D is capillary refill time. So which is a prognostication or resuscitation tool for the mortality. Question number 2. The choice of inotrope in a patient with low cardiac output and adequate left ventricular filling pressure in septic shock. A, epinephrine, B, norepinephrine, C, dopamine, or D, dobutamine. Thank you. Since we are running short of time, we'll skip the lunch break and we'll go ahead with our post-lunch session. So I would like to invite the chairperson for this session, Dr. Anu Kapoor. Ma'am is senior consultant and is medical superintendent and as well as the past ISA Delhi, President ISA Delhi. Ma'am is working as medical superintendent in NDMC Medical College and Hindu Rao Hospital. And ma'am's area of special interest are intensive care, trauma and disaster, pediatrics and obstetric anesthesia, and airway. We welcome you, ma'am. And I hand over the proceedings of the session to you, ma'am. Over to you.
Unmute, ma'am, please.
Ma'am, we are not, yeah.